So, what are the complications of primary pulmonary cocci? Well, what we get first of all is pulmonary residua. So you get this pneumonic process and then it has to heal. And in healing, one gets a variety of processes. And we're going to talk about those nodules, cavities, and then complications such as pneumothorax or chronic disease. One of the most common things we see are nodules. And a nodule is a resolution of the initial pulmonary infiltrate. Nodules are almost always benign. They may cavitate and cause a cavity, but other than that, they will usually resolve. The problem with a nodule is that unless you've actually followed it from the time of the pneumonia, these are very, very difficult by any means to distinguish from a pulmonary malignancy. And what I've learned over the years is I'm an infectious diseases doctor, so I have sort of a different view of malignancies. When I work with my pulmonary colleagues, they are extremely aggressive about excluding a pulmonary malignancy, and that becomes a big problem in Arizona where nodules are frequently due to coccidioidomycosis. And that's where the whole problem resides. Now here are some examples of nodules. Here's a patient that begins with what looks like a mnemonic process, fairly dense, and then even just 10 days later is already sort of defining itself. And if we look here, by the end of the month, it's already sort of rounded up. So when we have those cases, we're in good shape. Now, what I tell all my patients, whenever I see them for primary pulmonary coccidioidomycosis and I see this evolution, is I educate the patient that they are developing a nodule and they need to do that. Because and we've had this happen, they go out, they're driving on Speedway and they get in a car accident and they go to another hospital and they get an x-ray. And I've actually had this happen and the radiologist will say, can't exclude a pulmonary malignancy. And at least on one episode, the patient came back, was very upset, and we could show the patient all his x-rays and show, no, your nodule's exactly the same, don't worry. So all patients need to be educated about this evolution because if they go somewhere else, have a chest radiograph, the default is to say this is likely a pulmonary malignancy for the very reasons I told you. People don't want to miss these. I actually have a patient right now in Minneapolis, the same issue going on, where we're working with the clinicians at the University of Minnesota and at the VA to sort of sort out this patient's pulmonary status. Did he have a malignancy with his cocci? And we have to work that out. But in many cases, you can sort it out just by having serial chest x-rays. So always educate your patient about this. So here's a classic solitary nodule right there. So how do you approach these? Well, again, it depends who you are, but I'm an infectious diseases doctor, so I'm not quite as aggressive as my pulmonary colleagues. So if I have a patient who's a non-smoker, a positive serology, and even if I've seen that evolution, I'm probably not going to do anything. But let's say I just come up with this nodule, they have a positive serology in the non-smoker. I may simply get x-rays over time after discussing that with the patient. Now, clearly, if the patient's nervous about that, I might send them on. But if they're okay with that, I might just follow them radiographically because nodules get smaller and malignancies get bigger. Now, PET scans are frequently positive, and this has been a big bugaboo. We're trying to publish these data. PET scans are frequently positive. In our experience, 80 to 100% of coccidioidal nodules are going to light up on a PET scan, and they're going to light up in a way that's a malignancy. So you'll often see people going to PET scans. Now, PET scans will pick up, they are used to stage malignancies, but it's well known that they're positive in infections. It's just that somehow everyone's forgotten that. I don't understand why, because it's extant in the literature. But so pulmonologists in particular, when they see a nodule, will get a PET scan. If you do that in coccidioidomycosis, it's going to light up. And not only will it light up in the nodule, it may light up in the mediastinum. And then the patient will be told, as once happened in a patient at Boston Medical Center I was called about, that they have inoperable lung cancer. And I'll show you those in a moment, but please be very wary of ordering PET scans. Our feeling is they give you no additional information to manage the patient with a nodule. Finally, when to do biopsy? Well, if there's ever any concern, certainly if the patient is a smoker, certainly if the lesion is growing, if there's any issue at all, then one should go on and attempt to biopsy that nodule. So here's just an example of a PET scan. So and PET scans are done by combining currently by combining a CT with the positron emission, and then you get this combined film, which you see on the bottom. So here's just a CT scan of this pulmonary nodule that you can see in the left upper lobe. And then you can see the PET lights up, so you end up on the bottom with a positive lesion. So, and this is a case of established coccidioidomycosis. So these things do light up. As I say, we had them light up in the vast majority of cases who had coccidioidomycosis. So if you're going to do a biopsy, what might you do? Well, the most common thing is bronchoscopy with transthoracic biopsy, or percutaneous fine needle aspirate. But realize in both these techniques, you may not get to the lesion. So you may come up with a negative test. Now, if you do that, what you're supposed to do is do it again. But what frequently happens, particularly with either of these methods, is the patient will get a small or sometimes large pneumothorax. So everyone's enthusiasm for doing this again kind of drops dramatically, both the patient and the physicians. But realize it's like you didn't do anything. You may have dropped the patient's lung, but you didn't make a diagnosis. So either you pursue that or you're back to doing what I frequently do, is following the patient. Now, you can be more invasive and do video-assisted thoracotomy or even open thoracotomy. One of the strange things I've noticed when I interact with patients or with the public is the angriest patients I've seen are patients who've been operated on for these nodules and then been told, oh, this is coccidioidomycosis. And I still don't quite understand it, but I think it comes from that they've been told that they have a pulmonary malignancy, that they need to undergo these tests or this test. Sometimes they have complications from it, and then they're told, oh, never mind, it was benign. So there is a downside to being very aggressive with these nodules when they turn out to be benign. So let's move on to cavities. So cavities are the result of a previous nodule that has excavated. It's actually gotten into the airway, so the material inside the cavity can then be coughed out. Most cavities are completely asymptomatic, but there can be symptoms associated with this, including cough, hemoptysis, which is usually mild, but again is a very disturbing symptom to a patient, pleuritic chest pain, and frequently the sputum culture is positive. Now, these will close without therapy, but not if they're large. So if they're greater than 4 centimeters, these are likely to persist and may have cause problems. And one of the problems they cause is they may become secondarily infected. And they get secondarily infected with 3 things. They may actually get secondarily infected with coccidioides itself. So the cocci will actually start growing as a mycelium in the cavity. And that can be irritative and cause coughing. Occasionally we'll see an aspergilloma in those. And probably most frequently is these get secondarily infected with bacteria. So sort of antithetically, you would end up treating these cavities with antibiotics because you'll see them, they'll actually fill up. There'll be a cavity and suddenly they'll become radio-opaque. And the patient's cough will increase, and often the answer is to give them an antimicrobial, an antibacterial, in addition to an antifungal because they become secondarily infected with a bacterium. So here's a rather large cavity in one of my patients, and she recently actually underwent an extubation of this. We finally convinced her. And one of the issues we've seen when we've done surgeries, often cavities return after surgery. But this cavity is very unlikely and didn't close on its own. It's much too large. Here's a smaller cavity with an air fluid level. And when we did a CT scan, you can see there are actually two cavities, the one anterior with the air fluid level and the other not. And generally cavities are reported as thin-walled, but as you can see, these aren't strikingly thin-walled, and these are due to coccidioides.